Before we get started with talking about intellectual disabilities, a couple things that I want to bring to the forefront in terms of controversy or considerations. When we're talking about intellectual disabilities, and as I lead into the next couple of slides about how we define intellectual disabilities, it's important to realize that there have been some pretty legitimate concerns about the misdiagnosis of minorities in this disability category area. In particular, we see an overrepresentation of African American males in the intellectual disability category. So that has continued to be a concern. There's also a lot of stigma attached to this diagnosis. We know that intellectual disabilities used to be called mental retardation, and we know how that has kind of evolved over time. And again, the stigma attached to having that label. Parents have a hard time often with coming to terms with hearing that their child is going to be labeled with an intellectual disability, and teachers have a certain idea or perception of what these students are going to be like before they even get them in their class. So the last piece to consider is that, intellectual disabilities really is a socially constructed condition. We have set a parameter for what we consider to be the cutoff for IQ, the cutoff for adaptive behavior, and so keep that in mind as we're talking about the definitions. The American Association for Intellectual and Developmental Disabilities have generated definitions for intellectual disabilities, and as it was called previously, mental retardation, over the years. And you'll see some of the same vocabulary, some of the same terminology repeatedly throughout the definitions, through the evolution of the definitions. The one thing that you'll see is the sub-average general intellectual functioning. You'll also see this being originating during the developmental period. In other words, it's not as if the child developed normally and then all of a sudden developed some intellectual disability. It started off as the child was developing. And through time, you'll also see the introduction of adaptive behavior, which is a really important component as we start talking about how the legislation changed and how our identification of ID changed over the years. Up until 1992, the definition for ID was pretty limited. It talked about that sub-average intelligence happening, concurrently during developmental years, and there was just the beginning of some discussion about adaptive behavior in the late 80s. By 1992, not only do we have the things that I just mentioned, but we're starting to really define adaptive behaviors into categories like communications, self-care, home living, social skills, community use, self-direction, health and safety, functional academics, leisure, and work. And so the definition really started to expand, and we started looking at the individual in more than one scope. So instead of just looking at IQ, we started looking at what is the individual, what is their environment, and what types of supports do they need to be able to function. The other thing that became really important was that we needed to start looking at the individual beyond just an IQ score, but we also needed to look at the adaptive behavior in light of how that particular child or young adult interacted within their community. You can see by 2002, we again have the intellectual functioning as well as the adaptive behaviors. And we also start looking at kind of a comparison of limitations. So the limitations that individuals are experiencing are within a context of their community, like we mentioned in the previous definition, but it was a comparison as well to the individual's peers and age group, so that we could actually look at what would be the norm for the adaptive behavior for this particular student. One thing that I didn't mention in the last slide, but that also was pulled in, was that the disability originated before the age of 18. So before we were saying it had to have happened when it was, during the developmental years. And what we came to learn is that we can't always identify those developmental years as being the catapult for the start of the disability. Sometimes we don't know until a little bit later on. So it was important to expand that definition, and it also helped to um, cover individuals who would have been under the American Disabilities Act and not just IDEA within the school system. By 2010, we had the working definition that we use today for intellectual disabilities, and it was in 2010 that the word mental retardation was replaced. So this is a relatively new development and evolution over time of this disability area. There was a committee that really emphasized more the positives as opposed to the detriments of ID, and ID became the focus of ID went away from kind of describing it as a state of functioning. So if you're ID, you do these things, to this is just a trait of who you are, and these are all the other things that you could be good at or that you are able to do. So we moved away from kind of the disability first, if you will, and we finally moved to a person first approach to the definition. There is some discrepancy about the number of students who have ID in the public school system, and this is primarily because we're in this time of change with moving away from an IQ score to this adaptability scale. So some say it's as much as 2.27% of the population, others say it's as low as 1%. And the discrepancy is really where is the cutoff for the IQ, and was the adaptive components, were those adaptive components considered? So those who had the higher IQs, were they considered learning disabled even though they maybe didn't have any adaptive skills and could not be self-sufficient or could not live independently because they don't have the ability to make the judgments and to kind of maneuver themselves through the community. So there is that discussion. Ultimately, it is a label. How much it matters, I don't know. In terms of instruction, whether or not we know if we have 1% or 2%, what we do need to know is what our students need, and then we need to provide those services to them. So don't get caught up on the prevalence. Just to give you a little bit of background when we're talking about the IQ scores and what the cutoffs were, this was in the caps that you watched, but it used to be that if you were 2 standard deviations away from the norm, then you were considered to be intellectually disabled. So it was a formula, and it was based off of this normal curve, this bell curve, if you will, where we expect most folks to fall within the first or second standard deviation away from the norm. When talking about some of the causes of ID, this is a list, not a comprehensive list, but a list of some of the prenatal causes. So these all happen before birth. They happen during the fetal development. There's a number of chromosomal disorders. I know you've heard of Down syndrome. Fragile X is, let's go back up to Williams syndrome. Williams syndrome is a genetic condition. It's present at birth. There's medical cognitive problems, cardiovascular disease. It affects about 1 in 10,000 people worldwide, and it can occur in both males and females in all cultures. Fragile X syndrome. Fragile X syndrome actually can look a lot like autism. Students tend to stim. They have difficulty transitioning. There are some physical characteristics that have to do with how the children actually look, how their features are kind of placed on their face, and but mostly Fragile X, like I said, it mimics autism quite a bit, but it has to do with a chromosomal deficiency or defect, as opposed to the cause that we don't know yet for autism. Prader-Willi has to do with an abnormality in a chromosome. It impacts males and females, and typically these children have low muscle tone. They are typically really short in stature. There's also this chronic feeling of hunger, so the children are very frequently hungry and eating to the point that they become overweight. The average IQ for these students is about 70. So there's other issues as well with social and motor deficits. The other are just kind of overarching inborn errors of metabolism, developmental disorders of the brain, environmental influences. So when we're talking about causes, we're talking about prenatal care as well for children. And sometimes we don't know the exact cause other than to know that the mother was not getting prenatal care or taking the best care of herself when the child was in utero. Other potential causes include those that could happen at the time of birth, anoxia, which is um, the stop of oxygen, so the baby has their cord around their neck, or somehow there's not oxygen, oxygen's not getting to the brain. Low birth weight or some sort of infection that's passed from mothers. There's also a series or theories out there about postnatal causes, including biological postnatal causes as well as psychosocial, which is when the child isn't getting what they need to fully develop. So in some of those situations, it could be instances where children are kept, in a crib for years upon years and not given any human interaction. So those would be the types of psychosocial causes that we would be referring to. This table further breaks down some of the causes. I know it's not crisp, but you can see the chromosomal abnormalities, some of the examples, as well as metabolic disorders, maternal infections. So this gives you kind of a bigger picture if you wanted to know exactly what some of those disorders were that could potentially cause ID. So when we're talking about how we know or how we come to the conclusion when we're going through operational criterion worksheets and trying to place a student in special education and looking at labels, there's a couple things that we're going to base our evaluations on. The first thing is going to be the intellectual disabilities. So you have something like the WISC or the Stanford, but the problem is, of course, that you are going to be overly relying on IQ scores. So are we going to get into that situation where we're just saying, here's the number and that's going to be our cutoff? We need to also make sure that we have some flexibility with how we're interpreting the IQ scores, and we're considering the cultural biases that could be coming into play, especially as I mentioned in the very beginning, that we have a disproportionate number of African American males within this category. So we do look at intellectual ability through IQ tests as a starting point. The second area we're going to look is at adaptive behavior, and this is the degree to which the student can engage in their environment. It's what is expected for them in terms of independence, social responsibility, peer interactions, for their age, for their peer group. There's a couple of different scales that can be used. One is the AAMR adaptive behavior scale. There's one for school and then there's one for residential in the community or for home. And the other piece is just to assess their adaptive behavior in terms of being able to access transportation, make a phone call. Are they able to use the internet to find, the bus schedule, or to order in a restaurant? Are they able to pay their own bills? So doing that type of assessment of adaptive behavior is also a key component on top of all these standardized tests that we're referring to. As with any disability area, there are effective instructional techniques. First and foremost, you want to make sure that you have high expectations. Don't let a child's cognitive ability or intellectual disability deter you from having those high expectations. What's also really beneficial for students who have intellectual disabilities are things like cooperative learning, or inclusion strategies like modifying instruction, organization, collaboration, and you want to make sure that you're also monitoring the progress of all students, but particularly those with students with intellectual disabilities, so that the gap isn't becoming wider between those students and their peer group. I'll talk about task analysis and scaffolding in the next two slides. Often when you're working with students with ID, completing something like a task analysis is very effective for students because it gives a breakdown of the step-by-step components that are needed to finish a task.